Thank you. Thank you for the invitation. Thank you for the opportunity to have the possibility to exchange with the neurology community in this Congress. So the question today is if CCSVI, a syndrome that you may depict in this picture, is characterized by blockages of the venous outflow from the brain, and mostly are intraluminal defects, very teeny septa, valve malformation that create significant flow disturbances, and the minority of cases are segmental hypoplasia. I subset my speech today in 4 main sections. One is, does CCSVI impact brain pathophysiology? The evidence of microbleeding and perivenular iron deposition. Some of genetics. Does HLA regulate just immunity? And finally, some comment on the first epidemiological available data. We start from pressure data. These are measured by catheter venography. You may see a significant stenosis in one of the jugular vein, depicted by venography, and we measured, on average, a gradient across the stenosis of 2.2 millimeter of mercury. This is a significant difference. It seems a little difference, but in the venous system, 2.2 millimeter of mercury is a big gradient. And so, at first, we considered that this difference may probably impair the reabsorption of the CSF flow at the level of the superior sagittal sinus. So we decided to design a study in cooperation with Buffalo Neuroimaging Analysis Center, and by measuring the CSF flow at the level of the sylvium aqueductum, we found a significant difference between MS patients and control. So the net CSF flow is reduced in MS. And interestingly, very interestingly, the CSF flow impairment is inversely correlated with a score that is a venous hemodynamic insufficiency severity score that is based on the number of venous segments at the extracranial level exhibiting flow anomalies in the different postures. And we found a significant inverted correlation. Also, CCSVI is related to hypoperfusion of brain parenchyma. Look at picture A respect to B. There are 2 RR patients. The first A patient is with a venous hemodynamic score of 5 respect to 12 in B. And you may see the dark area very well depict the hypoperfusion of brain parenchyma expressed by cerebral blood flow. And this is coherent with the same 2 patients below, in which you may see that the mean transit time is significantly prolonged in the patient with a major venous hemodynamic severity score. And this is the concept of venous insufficiency, a prolonged transit time. There is a robust correlation, this paper is impressed on BMC Neurology, between the venous hemodynamic severity score and MR perfusional parameter. There is a another very interesting phenomenon, that by increasing the severity of multiple sclerosis, there is a reduction of venous vasculature. Panel A is a normal subject with a system called, very advanced system in MRIs called SWI, and is capable to assess the vein without contrast media, thanks to the assessment of the hemoglobin. And you may see that by increasing the severity of multiple sclerosis, you have in B2, is a classic relapsing remitting early patient, you have a coherent reduction of the vein in the white matter, and you see the disappearance of veins in a secondary progressive patients. We don't know why this phenomenon happened. This is very important for the research, for next research. And this is a paper presented at the last American Academy of Neurology, and you may see the difference in venous vasculature between healthy control, relapsing remitting patient, and relapsing remitting patient with a greater EDSS. But interestingly, the reduction of cerebral venous vasculature is related to both the Venous Hemodynamic Severity Score, CCSVI, and also to the EDSS scale. And the reduction of the drainage of brain parenchyma, very well depicted by this advanced MRI system, report us to the virtual hypoxia mechanism for chronic demyelinization and axonal neurodegeneration and multiple sclerosis that was superbly depicted by Trapp in this review last year on Lancet Neurology. But if you compare the conclusion of this review with another review published on the New England Journal of Medicine in 2006, depicting and reviewing the mechanism in chronic venous disease, you note that impaired venous drainage reduced significantly oxygen utilization, resulting in increased mitochondrial demand with oxidative stress and nitric oxide production. So this means probably that there is a contribution in neurodegeneration due to the less efficient system of drainage of the central nervous system. Second point, this is a model of venous obstruction in animal, and this is an electronic microscopy that show you at the venular level the enlargement of the venule with enlargement of the tight junction and the possible diapedesis of red blood cells. It's very well depicted. This is a model, and an animal model, and this led over time, to the chronicity of this obstruction, to extravascular hemolysis and tisutal iron stores, both linked to ferritin and hemosiderin, or taken up by macrophages. And there are neglect pathologic picture in MS related to CCSVI. For example, perivenous iron store. Look in panel A, you may see a vein exactly in the center of a plaque of a mass, encircled by the blue stain is iron due to the hemolysis of red blood cell that crossed the BBB. Also, fibrin cuff encircle and thickened the vein. This is a sign of venous hypertension. And iron-laden macrophages show clearly that a part of these inflammatory cells migrated to taken up iron. So venous wall and perivenous tissue both show typical histology of chronic venous stasis. This is more evident at the level of subcortical gray matter and are really a neglected part of MS pathology, despite very good paper published along the history of the research of this disease. But this histology nowadays can be easily seen by advanced MRI technique. You may see MS in the only neurodegenerative disorder with iron stores in the white matter. Alzheimer, Parkinson, and other neurodegenerative present really iron stores. But MS is the only neurodegenerative disease with iron in the white matter and, interestingly, encircling the vein wall. So really resembling the pathology, the histology that I showed you before. Iron stores are really related to the venous hemodynamic severity score. So there is a more higher chance to have more iron in the subcortical gray matter according to the number and the degree of stenosis at the extracranial level. Increased iron stores in the subcortical gray matter are also related to disability score. One of the first regions that are interested in iron loading is pulvinar thalamus. This is really the first target. So we have chronic obstruction at the extracranial level and histology, pathology confirmed by advanced MRI of extravasation of red blood cells encircling the venous wall and other signs of CCSVI. Genetics. We measured copy number variation through a high-resolution susceptibility comparative genomic hybridization. This is a technique very, very precise, certainly more precise with respect to PCR, and also give us the opportunity to analyze the pathways, the genetic pathways. In HLA locus, we identified in this cohort 234 polymorphic copy number variation. And there is an interesting correlation between the number of copy number variation and the number of stenosis or malformed vein at the extracranial level. Pathway analysis revealed common interaction of some genes that serve both for angiogenesis, vasodilation, vasoconstriction, so vascular function, and immunity. Although preliminary, this pilot study suggests, it is published on Medical Genetics, that the number of multiple polymorphic copy number variation in the HLA locus may deserve further study, possibly being involved in susceptibility of a sole MS, but also of a novel MS-associated CCSVI phenotype. Comment on the first epidemiological data. By using our criteria Doppler, the prevalence of CCSVI in MS range from 56 to 100%. There are also papers coming from Middle Orient showing 84% prevalence, other paper coming from Central and Eastern Europe showing 92%, 21%. To the contrary, by using magnetic resonance of different Doppler ultrasonographic protocols, there is no evidence of CCSVI in MS in 2 papers published on the Annals of Neurology. However, magnetic resonance is not a good tool for detecting CCSVI because by assuming catheter venography as the gold standard in medicine, there is no agreement between magnetic resonance and catheter vein in 70% of cases of CCSVI MS patients. To the contrary, color Doppler, according to our criteria, and catheter venography show that respectively 99 and 95 positive predictive value and negative predictive value. And this is a paper in press on the American Journal of Neuroradiology. In another paper, catheter venography showed in 700 consecutive MS cases 97% evidence of CCSVI. It is an invasive tool yet. So we definitely need a non-invasive and non-operator dependent diagnostic methodology. And I hope to give you an answer about this along the next year. Some comments on the Doppler Buffalo study. You may see that CIS showing 38% of prevalence of CCSVI. This means that for demyelinization, it's not necessary to have CCSVI. But if you look to relapsing remitting, 55%, and to secondary progressive, 76%, it seems that CCSVI ingredient may worsen the prognosis, so may increase the possibility to evolve from CIS to relapsing remitting, so to establish a diagnosis of multiple sclerosis, and increase also the chance to go into the secondary progressive. But of course, these are cross-sectional study, and we need longitudinal data. Is CCSVI linked with MS pathogenesis? Yes, in my opinion, because CCSVI contributes to virtual hypoxia, an underlying mechanism of neurodegeneration. And I showed you why, because CCSVI syndrome is related to hypoperfusion and to a reduced venous volume in advanced MRI. The integrity of BBB in MS is a fiction because there is evidence of pathology and also of advanced MRI of extravasation, microbleeding, and iron stores encircling the vein. Iron stores correlate with clinical disability. Lesion volume does not. Iron stores encircle the vein wall also in the white matter. Copy number variation of regulatory genes in the HLA locus correlate also with CCSVI and not only with MS. A prevalence of CCSVI in multiple sclerosis prevalence study is often significant, although strictly linked with the methodology used. Thank you for your kind attention.
For discussion. Is there any question?
There are many questions, just one. Why should venous congestion be confined to the brain? Why shouldn't one see also this phenomenon in other organs?
Yes. The phenomenon that I showed you is general phenomenon.
No, but in MS patients.
In
MS patients.
Yes, in MS patient, in other outcomes. Yes, really, I tried to perform this kind of analysis, but unfortunately, the prevalence of venous insufficiency in the leg is very, very high. So we need really a very large cohort study in order to elucidate this. What I noted are the presence of malformation in our district in MS patients. For example, Cockett syndrome, that is a compression due to anomalies in the disposition of iliac vein and the aorta. I noticed a lot of truncular venous malformation like angiomas and other malformation at the level of the skin. And probably this is a good suggestion for further study in this direction.
Joanna Wojciech from Medical University from Lublin, Poland. I want to ask you, what do you think? I examine a lot of patients with MS and any other person, and I could find in ultrasound venous insufficiency only in, according to your criteria, only in patient with heart failure, especially right ventricle failure. This is a big insufficiency, venous insufficiency, and the patient did not develop MS. How can you explain it?
Yes, I may explain this very well, because you may found some reflux coming from the chest in this patient.
But,
Okay, so this is reflux coming from the chest. In this patient, in MS patients, reflux is not coming from the chest. It's the expression of a little segment with a reverse flow that try to find a collateral path. For example, if you detect reflux in the jugular vein, it's not coming at all from the chest. It's venous volume of the cervical part that is impaired in the drainage. And try, for example, to find the superior thyroid vein coming down through the thyroid gland and regain the caval system through the inferior thyroid vein. But all the quote of venous volume is not coming from the chest. It's venous volume of the brain. It's completely different. And you have a prolonged time. I think that in the next months I published a system, non-operator dependent, through plethysmography that show you very well that you have a big delay in draining the blood from the brain toward the chest, but no impairment from the chest to the cervical part of the body. This is the problem.
And can I have the next question? Okay.
Professor,
Okay.
Thank you, Professor Zamboni. I have really two very quick and probably related comments or questions. The first is, we all acknowledge there is a problem on the venous element in MS, but we don't know what is cause and what is effect, and I don't think your presentation explains what is the cause and effect relationship. It might well be what Colin Adams had presented in the 1918 JNNP paper was meant to be the effect of chronic MS secondary to whatever that happens. The other question is, which I think is equally important, from an anatomical point of view, we know that in the spinal cord, the highest level of venous congestion occurs in the lumbar area because of the natural effect of gravity. But we also know from MS pathology that typically it is the cervical segment which is worst affected. So how do you explain this anomalous relationship?
Thank you for a very good question. You are right. Really, I don't know if it's a cause and effect with the available data now. And my point is that this is a mechanism certainly present in the pathogenesis and probably is a piece of a mosaic. And I would like to invite you to consider this very well, and proceeding with research, we may understand a lot of new things, I think. Regarding the spinal cord, this is a beautiful question, because in my life, I had the opportunity to perform, prior to the CT period, a lot of azygosgraphy for pulmonary neoplasm. So I know very well the hemodynamics by venography of the azygous system in normal patients, because I performed hundreds of this examination. And after the injection, you have immediately the drainage of the azygous system to the right atrium. In this patient, you have a stagnation of blood in the azygous system for seconds and seconds. It's really unbelievable. And this is due to valve malformation and stenosis in the upper part of the azygous vein. Again, the hemiazygous system is really overloaded. In fact, if you should measure in the angiogram the diameter of the hemiazygous left renal vein is really increased in MS respect to control. And this because this is a collateral circle that permit to regain the caval system, although in the inferior part of the inferior vena cava. So this is a very efficient system, and, but unfortunately, the time of drainage is really prolonged, and is prolonged for the entire life. This is the difference. Again, we found also a correlation between the agenesis of the lumbar system and the appearance of primary progressive form. This, I think, it is important and need of further evaluation independent from our center.